This is Impact Healthcare, people and strategies that are disrupting the health benefits industry. And now, here's your host, healthcare benefits industry expert and the originator of the transparent health benefits movement, Lester Morales.
Welcome back to another episode of Impact Healthcare, and somebody I've recently met, but it's funny because at the end of the world, this life of people who are trying to improve healthcare is actually small. So Jordan actually knows somebody that was my old boss and somebody who got me into really understanding this space of advanced primary care. But Jordan, for the audience out there that might not know you, your great company, give us an introduction. And knowing you, knowing people that get up and, again, swim against the current, do something different, innovate, there's always that motivation, that why, the pep in the step. What peps up your step?
Yeah. Thanks, Lester. Awesome to be here. Jordan Taradash, CEO over at PeopleOne Health. So many terminologies out there: advanced primary care, direct primary care. You can put us in any one of those buckets, but fundamentally what we are doing is creating a high value, high access, high relationship entry point into the healthcare system for employers and their employees. It is, we don't get up every day and try to create the opposite of the current healthcare system. That's not the motivation. But what we do is think of, if we are delivering this healthcare to our family, our mothers, our sisters, our brothers, our kids, how would we want them to be treated? And that's how we build our entire organization. Getting up every day, why do we do this? It's a little bit different than what some might expect. I have a deep, passionate connection to disease prevention because it's like there's something we can do about chronic disease prevention, right? And think of all the improvement in life and milestones in life that people can achieve if we help prevent type 2 diabetes or prevent premature death or whatnot. But I care about that deeply. But the truth behind it is, what I am mesmerized every day is our care teams, the clinicians, and how they dedicated their lives to caring for others. So that's my mission. My mission is to create the environment so our care teams can live out their mission and really provide exceptional care for our members and the people we care for.
Love it. Love it. I often forget about that other side, being on the insurance nerd side. So thank you for that reminder. So this isn't the first time somebody in the audience is going to have heard making it easier, better, all of the cliche, maybe I've heard it before, or, things. And getting to know you more, I understand there is a true difference. The question I got, Jordan, why now? Why is now for you? Why now for the industry? Why now for everything? Why now are you feeling really confident that the momentum is there for change and change for the better?
Yeah. I think the saying is right. No change happens until the pain of not changing is bigger than the pain of changing, right? And the current system has created so much pain that now we are at the time where the pain of not changing is bigger than the pain of change. And that is an economic pain, right, Lester? That is the dollars and cents that I think by 2033, and we're not that far away, the average family premium, Lester, is going to be equal to the median family's income in the United States. That 100% of your median family income is going to be dedicated to healthcare. So how do you live anything, no rent, no food, that it's just unsustainable, right? And then the access and the care and the surprise bills and the bankruptcies and the months and months and months of wait times to get in. It's like, if you get into a room, which you do all the time, and say, hey, let me describe a scenario, and raise your hand if you've had any one of these, within a minute, every single person in that room is nodding their head, raising their hand, and the pain is amongst all of us. So that's why I think now it's unfortunate. I know you and I don't hope for this moment, but we know we're gonna capitalize it to make it better out there.
Yeah, no, I agree. So Jordan, let's for personification standpoint, the topic here, and whether again we want to call it direct primary care, advanced primary care, whatever, some might say, well, wait a second, that's the little piece of the pie. Right? We're not, when I look at my large claim report as an insurance advisor or an employer, I don't see an upper respiratory infection at the top of the list. Talk to me about the why it makes sense. And then I'd love to take people through what are the fundamental differences of how it's built to then address the big piece of the pie.
Yeah, really good. And it's a really important question because it goes to the core of what is the fundamental challenge in our healthcare system and why did we build this thing the way that we did? So, we know, like, if you think about the primary care office as a quote unquote box, right, there's 3 to 5% of total medical spend there, right? It's not even close to the big stuff. So what we did at PeopleOne Health is we acknowledged that math and said, wait, we can go further than that. Because if you think of the concept of a self-insured employer, where they are directly aligned with controlling the variable claims cost, right? So, because the vast majority of costs for self-insured employers when their people go seek care in a carrier-driven PPO network. But so much of that care happens over and over and over again, and it's high frequency. Why are we pumping that through an insurance system and processing and paying? That makes no sense, right? You know, I've probably said this 15 times when I talk to you, so it's not going to be interesting to you, but hopefully it's the audience. You don't get your oil change, your brake change, and your tires through your car insurance. You pay cash for it, right? But you have insurance for the catastrophic, unpredictable stuff. So, okay, we said, let's build healthcare like that. So let's take your highly frequently occurring stuff, behavioral health, physical therapy, imaging. I won't list it all for the sake of time, but remove all of that, allow employers to pay cash for it, and then just use the insurance mechanism for the unpredictable stuff. So Lester, when you do that, you unlock 30% of the cost of healthcare right there. Now, that doesn't fix the catastrophic claims and the high cost claimants and the big stuff you were talking about, right? So let's talk about how do you get there through primary care. You know these pieces. Every high functioning healthcare system in the world has primary care, high value, deep relationships at the center of it, right? So it turns out when you give people unlimited access to and a deep relationship with primary care, you affect the utilization and the health behaviors of everything else that comes downstream. And I'll give you some stats for this, right? So when primary care has enough time to address the needs of a patient, of a member, 75% plus of specialist referrals disappear because the primary care physician can actually manage those and take care of them, not just practice defensive medicine, right? 25% of ER visits will disappear. 75% of urgent care visits will disappear. So all of a sudden, you have a patient who is being cared for and not just pumped into the system, which is designed to create more care, more cost. I'll pause there because then we could talk about chronic disease and health behavior as well also. So I've been talking too much.
It's so interesting because until you see this, I don't think you can understand it, right? Because I truly don't think so. And I'm gonna hit two cliche things that I learned in this that revolutionized the way I was thinking. Number one, I would always think, hey, I'm an advisor. I have my employer. We hire you. And in the world of advisors, the naysayers are going to say, people are going to use a on-site, near-site, and they use the word clinic, which I don't like that word, right? It belittles the whole point of it, but they're going to use it for snotty nose and episodic stuff. right? So again, I don't get blown out of the water with an upper respiratory infection and some more amoxicillin, right? That's not what's blowing my cost up. And I remember the fundamental mindset that triggered the bridge for me, which was when our leadership would talk to the clinicians, they would say, treat the patient for what they came in for, and then treat them for what they need to hear. And that psychology of building the trust, like you said, and not what we used to call treat them and street them, is the fundamental difference in what we're talking about with the 3 to 5 minutes. I see 2,900 people a day, doctor's office, fee-for-service system, and the highly functioning advanced primary care. That bridge for me was the aha moment. You have to have a story or something to speak about that. But I just want to share with the audience, like, for me as an insurance nerd, not being a healthcare provider, I hate the smell of blood. I still look away when I get a needle. Like, I could not do this for a living. But that fundamental bridge was the aha moment. What would you say around that?
Yeah, I'll tell you a story. And this is a real one that'll be anonymized, right? I'll make up names. But there's an individual who we care for, and they came in for, like you said, snotty nose, upper respiratory thing. But then what else was going on? What else could we talk about? And all of a sudden we start hearing, I do have this intermittent chest pain stuff going on, but it's not a big deal. So if you're in the current system and you try to get a prior authorization for that kind of description, you're never going to get a stress test, or it's going to take 15 attempts to try to get. But in this system, it's like physician knows patient, physician knows something's going on here. No prior authorization is needed. When our physicians say a stress test is needed, we order it, that person's there. So that person the next day has a stress test, okay? They're on the treadmill and they go into cardiac arrest. They're on that stress test. Thank goodness they're in the right setting to bring that person back to life. And then they were treated and cared for. The next time that person went out to shovel snow up here in Pennsylvania, they would have died because they would have been alone and they would have never had that stress test in the current system. Or let's say they survived, but they would have had so much cardiac damage and hundreds of thousands of dollars of bills. Instead, you have somebody with a $52 test that saved hundreds of thousands of dollars down the road.
The second cliche that I never again appreciated until you start to now be in a model that allows you to dig in through claims experience, which is the cheapest heart attack is the one that never happened. And the reason that didn't happen is because they spent so much time with a clinician that wasn't trying to get them in and out, because they spent so much time in a model that there wasn't any adverse conflict to, I'm a diabetic. Let's say I have 16 things over the course of the year I need to do to stay compliant. But in my current health plan system, 16 things times, an average office visit of X and the time out of work and blah, 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 it just doesn't work. So then a compliant diabetic costs $2,000 a year. A non-compliant kind of diabetic costs $68,000 a year. Like, again, I'm not great at math, but this is an easy thing. Talk to me about that, because that's the bridge, right? That's the trust, the model, and why it works in the delivery of the two biggest things that people are looking for, which is health improvement and cost improvement. Talk to me about that bridge.
Yeah, that's awesome, Lester. So we already talked about the first layer of cost savings, which very simply is keep people out of PPO networks and fee-for-service, okay? That's just an arbitrage, but that's not health behavior change. The next step is really what we're all trying to get to, which is what you're talking about. So let's keep going with your individual type 2 diabetes. Not only is the uncontrolled type 2 diabetic that much more costly, but take somebody who's comorbid with type 2 diabetes and a behavioral health challenge and depression. Okay, right? And the current system is treating their behavioral health over here, their physical health over here, and none of that works. Now create a care model where not only your primary care physician has time to dig into both, but you have a licensed clinical social worker that's part of the care team, and behavioral health that's part of the care model, unlimited access to that. So that's the differentiator. You cannot treat type 2 diabetes by treating A1C. You have to treat the human being, their comorbid conditions, their behavioral health challenges. Because if you're struggling with type 2 depression, you're not going to control your A1Cs because all those behaviors are complex. It's just not going to happen. So surround the member, the patient, and the physician with all of the care team that they need and all of the resources. It is that integrated approach. Then all of a sudden you have a type 2 diabetic who their depression's treated, their A1C is in line, and they have a chance to get back to thriving at life, not just hopefully surviving.
So I want to go back and address something because I don't want the analytical people in our audience, the old me's, right? The crotchety insurance advisor who looks for the reason to not do this. Because theoretically, when you go talk to an employer, there's this conversation that says, I'm paying for this over here. You want me to pay more money over here, blah, blah, blah. And you brushed over something that for you is very common sense, but I want to peel it back. And you called it an arbitrage, but I want to make sure people understand, because the way I have this conversation, and you and I are working on an opportunity together right now, that the only way that this group sees it is, hey, you're paying for this over here. We're just going to move those dollars over here, number one. And when your average unit you're paying is X, and we're reducing that unit to Y, because the misconception, and I really want you to dig into this for the numbers nerds out there, the misconception is you cannot lower the cost of healthcare. And so the warm and fuzzy piece is, hey, we're making people healthier. And then a CFO is going to say, yeah, that's going to take 2 or 3 years down the line, blah, blah, blah. But what I want to address is, yeah, we're going to do that, but we're going to pay for that off the savings that we're going to show you right up front pretty much immediately, because you can lower the cost of healthcare. Talk to me about that arbitrage and what that really means to the numbers nerds out there.
That's great. One of my mentors, I'm not a benefits expert or professional, never have been, but one of my co-founders and partners is, and this statement is claims are claims are claims are claims, right? Everyone who's right. Let's end it now, right? And that is just not the truth, right? It just isn't. So let's wonk out on it, right? So I'm gonna make numbers round just to make the math easy. Take a PMPY of $9,000. Okay, let's just first
let PMPY for the audience, just in case.
Sorry.
Per member per year. So per belly button covered under the plan, how much are we spending on that person in a year basis? Just in case there's somebody out there that doesn't know the acronym.
Thank you. Appreciate that. So everything that we're delivering in this kind of PMPM, per member per month, fully transparent bundle, meaning you pay one price and you get unlimited access to it, it accounts for about 40% of the cost. So take 9,000 times 40%, that's $3,600, okay? If that person's running through a carrier PPO network, that's going to cost $3,600 for that 40% of those services. That might be MRIs or physical therapy, whatever that it is. In this universe over here, that's going to cost $1,800 because it's a PMPM, fixed cost, unlimited access to all of those things. So would you rather pay $3,600 or would you rather pay $1,800? I think that the choice is pretty clear on that. That is your arbitrage right out of the gate.
And it's funny, my LinkedIn post today was exactly what you just said on a Keytruda patient, that it's like 17,000 versus 750,000. Which one would you rather choose? So I like the which one would you rather. So okay, we automatically sucked out costs out of the system. And let's go back and play with that diabetic. So that diabetic, comorbid, right? I'm dealing with depression. When I get depressed, I eat a bunch. I eat unhealthy. I don't manage my A1C. And now we see life happens. We all of us, you and I are pretty upbeat dudes, but life beats you up. So like there are times where you're just not going to be your best self. I get the clinical psychology and all those things, people, but talk to me more about that person. So the A1C is a portion of it. We got foot exam, eye exam. You have natural things that I have snotty nose over here. Talk to me about the rest of that care journey for that person, so that on the other side we can personify that person actually got healthier. I'd like to build that bridge.
All right, so let's start the economics and then let's get to the care. So why we talked about an individual struggling and how depression might affect their behavior, but there's something else that's affecting their health behaviors. And those are barriers to care, namely copays, deductibles, and coinsurances, right? So if you are this quote unquote Joe struggling with type 2 diabetes and depression, if you're managing your type 2 diabetes properly, you're going to the physician at least 4 times a year. Then you're getting your eye exams and your foot exams, and then you're getting your medication. The data shows that this hypothetical Joe, who unfortunately is not hypothetical in this world, is going twice to the doctor at most, skipping retinopathy and splitting his medication in half to avoid copays, deductibles, and co-insurance, because it is formal season for his child, and he wants to buy his daughter a dress, and he'll sacrifice his diabetic retinopathy eye exam to take care of his daughter. That is fundamentally real for 40% of Americans, okay? So the first thing we could do, Lester, is remove all those barriers. Say, Joe, all of that care costs you nothing. We want you doing that care. There are no cost barriers. So that's the first thing that we'll do. Then the next thing we'll do is we are going to have outreach to Joe, because we know Joe intermittently struggles with depression, right? So we're not going to wait for Joe to show up in the ER and then we'll grab him and say, oh, it's too bad, Joe, you had a heart attack. We're going to reach out to Joe and do check-ins on Joe, whether it be through our technology platform or through our social worker or through our primary care physician, and say, hey, Joe, you were in 3 months ago, doing well. How you doing right now? Anything going on? You struggling with anything? If Joe's doing great, fantastic. But if Joe's not, we're gonna bring Joe in and say, don't you have to come in? You have to get off the couch. Let's just do a telemedicine visit right now. Let's check in. Let me see face to face and let's connect. So economic point number 2, Lester, right? We don't have to drag Joe in to create a billable event and then try to create more economics for us. We have one specific goal. How are we going to engage and connect with Joe to maximize the care for him? So here's what plays out in Joe's life over time. Joe gets his care that he needs. He gets all his medication that he needs. He gets all his preventive medicine. He gets his behavioral health challenges. And then Joe has a registered dietitian who's saying, hey, Joe, you said you wanted to train for a 5K, but you just didn't think you could do it. You've lost 20 pounds. You're feeling good. Let's set that next goal. Let's get you trained for that 5K. So then it becomes aspirational. We're not a sick care system anymore. We are a health system looking to maximize the health and well-being of everybody that we're partnering with and caring for.
You know, it's interesting when you were talking about the dad wanting to get his daughter, right? The dress. It's interesting for those of us who have the economic means, right? That isn't, a $1,500, deductible isn't going to swing that one way. Having, grown up in a family who filed bankruptcy, and then seeing employers and talking to people that literally, to your pill splitting, to your things where it's like $25. And so I just had to kind of re-up that, as advisors, HR professionals, CFOs, let's just call that people who have the monetary means to be towards the corner offices. We might sit here and have a conversation that just raised the deductible another $1,000, or, hey, that's not that big of a deal, or what you said that, gosh, I want to rip my own tongue out because it's come out of my mouth before I knew what is possible. A claim is a claim. It's so not true the quality of the provider that's providing that claim is not the same as a claim is a claim. The cost of that claim is a claim is not a claim is not a claim. The amount that the person paid to get that claim is also different. And then the spirit of what would have happened if, i.e., I want the CEOs in this room to do me a favor. I want you to take your deductible that you have right now as a ratio to your lowest paid employee, and then take your salary and do the cross multiplication and say, what would that deductible be if it was off of your salary? And typically, if you're making $250,000 on this average day, we're talking $40,000, $50,000, $60,000 is the average out of pocket a CEO would pay to feel that same ratio as their lowest paid employee. But yet there are models sitting here that open the door, roll out the red carpet, and provide a win-win-win-win-win. So then I say, Jordan, why isn't everybody doing this? So when you talk to employers and advisors out there, I want to throw what their obstacles are and address it so that when somebody maybe hears this, they're like, yeah, I do have that same obstacle. He just told me what the answer was in the private of their own car or house or whatever.
Yeah. I think there are maybe three buckets of obstacles. Bucket number one is, you've already hit upon it, Lester, is the confusion that I'm going to double pay or I'm going to pay more, right? And any advisor who understands the math and who is a professional like you are can very clearly help a self-insured employer understand that this is not a double pay. This is actually a lower cost and an investment. So certainly comes up often, but one easily cross off the list. The next one will be, well, my people will have to change primary care physicians to do this. Like, my people they must have relationships with primary care, and they're not going to change those relationships. And just factually, unfortunately, not true. And you might go back to your analogy of a C-suite, high, kind of compensation individual who already have a concierge doc, right, that they're paying out of pocket. That's not what's happening, right? So the vast majority of average folks, 55% of folks, Lester, before the pandemic had not seen a primary care physician in at least a year. People do not have relationships. They can't get in to see primary care when they want to. And when given the opportunity to say, hey, you can choose this primary care offering if you want to, at least 30% out of the gate will opt into it. And that is all you need to say to the decision maker. Nobody's forced into it. They get to raise their hand and opt into it. So if they're happy where they are, stay there. And if they're not, here's a better option for you.
I love it. And that's strategically a model differentiation, because I can tell you that was not the model a lot of times that I saw. The economic model was, hey, you're going to pay this because people have the opportunity to come, and so you would come. So that was a much harder sell to a CFO who says, well, how do we know even people are going to use it? No. In your model and this model, someone's raising their hand and says, I like whatever that value proposition is, cost, quality, access. I go on the clock, whatever that is. So that's wonderful. I want to make sure we talk about two subjects. Number one is provider, because you said that in your conversation in the beginning, and I want to end with employee. So provider, in this conversation, my mom was a nurse for the VA hospital for 44 years. I've been around it my whole life. All of the stats, especially post-COVID, of how many people are exiting the business, suicide rates, how many people are in med school now versus, nothing tells us that the future in this world looks better. Talk to me about the provider angle of this and that overall satisfaction.
Yeah. Your mom did it. And, I don't know your mom, but I can venture to guess she did it because she was compassionate and she cared and she had mission, right?
Yep.
And that's the same of every single healthcare provider out there. They are stuck in a system that's screwed up. It is not the care teams. It is not the providers that are the issue. It is the system. So that's quadruple aim, right? We are doing this to also restore the mission of the providers and the care team members. You mentioned it. Primary care physicians have the highest suicide rate of any professional service comparable to veterans. Factually true. It's terribly unfortunate for all parties. They spend 2 hours in administrative work, clicking buttons and EHRs for every 1 hour of actually caring for folks. And they're taking their work home. And they're the lowest paid, quote unquote, specialist by far in the system. And it should be the opposite. Our value proposition is, listen, we know you are a compassionate, kind, caring person. That's why you got into medicine. How about we remove all the barriers? There's no insurance. There's no clicking. There's no administration. You see no more than 16 patients a day, and you get to go live your mission and care for people. And literally, Lester, last year, we had more physicians than we had offices. We had people that are like, give me an office. I want to get into this. These people are looking for a way to maintain their mission in life, but still maintain their quality of life. Otherwise, like you said, they're going to leave medicine, and that's a tragedy for all of us.
So Jordan,
good news. Oh, sorry. Yes, please go ahead.
I just want to make sure we don't. You said a number, but like it might not hit home if somebody doesn't know the reciprocal. You said 16. What's an average, primary care physician seeing in a day today?
35, 40,
so 50, more than 50% of the workload.
Yes, yeah, that's correct. It is crushing. It's crushing.
Wow. All right, and I interrupted you, but I wanted to make sure that point was there, because if it was, 16 versus 20, you might say whatever, but 50% less of the work, which means 50% more of the passion.
That's right.
Right?
The time, the relationship, do it, not feeling like, oh man, I didn't do the work that I needed to. That's just not fair. So the last part of this is, it's too good to be true, but it isn't. When you put a provider, a physician, a care team member in a position where they feel invigorated and able to do their work, and then you put them together with a patient, that is the magic that goes back to your first point. It's the 3 to 5% of spend, but that relationship is the activator for fundamentally changing the trajectory of this person's life, which could probably save hundreds of thousands of dollars in downstream costs. And that's why the math and the model all work.
I mean, it goes back to, if we want to take any old cliche, right? The black bag doc back in the day, the company doc. This goes back to all of those cliche, things that used to be the case, except that economics took over healthcare, right? That's just the reality. I had a LinkedIn post about this. If we took KPIs, you're a CEO, I am too. If we took the KPIs and said, okay, of any industry, whatever, let's look, double-digit rate increases, people filing bankruptcy, blah, 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 the healthcare and the health insurance industry would have an F-. But if you took at the compensation model and looked at the top CEOs of all of these organizations, they're making 16, 18, 25, $30 million. If you take their stock price since Obamacare is thousands and thousands of a percent higher. The model isn't broken. The model is designed wrong. And that's what you've done of primary care alongside of good insurance. Now you're flipping two models on its head. It's just fantastic. I want to start ending this with the thing I would have never understood unless I saw it with my own two eyes. And that is, man, healthcare. I would imagine an HR director, a CEO, a CFO says, man, this is getting personal in people's lives. Healthcare is super personal. They're going to think we have the claims information. They're going to think that I know I have a diabetic and I'm going to get fired. All of the conspiracy theory things that you and I both know employees actually really do think. But then what I found, wow, and I did this with 17 of my clients. The on-site, I would say the old version, not even your version. This would have been amazing. And the damnedest thing happened. It was the thing that maybe at first people were skeptical, conspiracy theory, whatever. And after that first year, if you would have tried taking this away, you would have had a picket line out front. This ends up being their number one, their favorite benefit, and a recruitment retention tool like no other. Talk to me about what the employees say about this.
Yeah. I'll give you an actual story about that. So this is a true client, CFO, did the longest diligence on us that I've ever been through before they pulled the trigger. Okay. And we were returning for the 1 year kind of review of the data. How did this savings look? And we knew how diligent this guy was. So we had our package ready to go. And they had a new consultant in there. And the consultant was like, hey, this sounds pretty cool. Jordan, can you tell me more about PeopleOne Health? And I opened up my mouth. And before I finished, the CFO jumped in and he went on for the next 30 minutes and talked about the care that he was getting, his family was getting, his employees coming into his office and thanking them for the care and whatnot. And that entire speech he gave, that impassioned speech, he spoke for 0 seconds about the cost savings. They were there, but that was not the story. It was how his people were being cared for, how he was being cared for. That is the ultimate value proposition. That will be the reason why when you place this as a benefit, either as a consultant or a CFO or an HR director, you will feel thoroughly overjoyed because of what you've done for your people, and it saved money also. I mean, what else can you ask for?
Man, when I think about, my favorite word, impact, right? The name of my company, the name of my podcast, and I think of Impact Healthcare, this conversation just, bleeds it all over. Let's just leave people with another case study. So, I want to make sure we hit all of the things that our marketing teams would tell us is a good case study. Like, tell me an employer, what they were challenged with. What was their hesitancy on doing this? What did they do and what were the outcomes? Like, let's walk through that on a specific group. I know about your business, so I know you're not going to just cherry pick one that we can go client after client after client, but let's just pick one or two and talk about it so the audience can really say, that sounds like me. I should probably, think about this.
Yeah, I'm gonna tell you one that it's a little bit different, Lester. It's actually a brand new client, and talk about their purchasing decision and why in the world that they went for this, right? So this was a public sector entity, okay? A unionized population, so the vast majority of the employees were unionized. And it was a collective bargaining situation. And, when you're a public sector entity, there's only $1. There isn't salary dollars and then healthcare dollars, right? There's $1. And in this collective bargaining, this group was asking for wage increases, as they should be. And the answer was, sure, we can do this, but then we're going to have to decrease your healthcare benefits, right? And it just created this incredibly contentious situation. And that is one that happens every single day in every single community in this country. And the answer was, there actually is a way to get the win-win. The answer is to put in a healthcare solution that increases the level of benefit to those members, decreases the cost to them, and saves the public sector entity money so that they can put those dollars towards increasing in wages, right? So I think we, Lester, together, and all the people in our armies of supporters and the people we are doing this work, imagine in every community in this country where we can figure out a way to maximize those dollars, increase the level of cost, and then not have to take that out of wages. That solves a whole lot of problems for a whole lot of people in this country.
And we didn't even get into, again, the dollars that never got spent in the current wage, right? So like if I have a copay, if I am the highest utilizer, in order for me to stay healthy, I got to go see the doc a bunch of times. So like that's a win on top of all of it, because it's about the money that I didn't spend as well. Jordan, let's end with, we talked about it, but we didn't describe it. It's a healthcare center. Is this on an employer's site? How big is it? Let's end just by personifying the four walls and what's in it and who uses it and all of that stuff. So again, I want to leave with the audience with okay, I have all of those problems over there I want to solve. Now, do I look like the demographics or whatnot? Talk to me about that.
Yeah. So I'm sitting in my seat as a CFO, HR professional, benefit consultant. Like, this sounds great, but man, I mean, I can't afford to build an on-site health center, and I don't have billions of dollars for that. The good news is these are community-based health centers that we build and we fund that multiple employers can share. And these health centers are these advanced primary care centers where you get all of your primary care and your labs and your generic drugs and your behavioral health and whatnot. And like you said, you get to raise your hand. So the employer is only paying for the members who want to engage. So no capital expenditures, only paying for folks who want to engage. And then the services that are wrapped around that, right? Imaging, physical therapy, cardiac and pulmonary testing, durable medical equipment. All of those services are wrapped in. They're not done at the center. They're done at our partner centers. But all of those services, that's about 88% of all the care that's typically hitting a PPO plan, never does. 40% of the cost, all included in this PMPM fully transparent rate. That's also for covered dependents and spouses. It's not an on-site center just for employees. It's for anybody who's on the plan. That's the overall offering. No capital expenditures to get through the door. Only pay for who's utilizing it. Accessible for all members on the plan, and just fundamentally caring for people each day.
So I am hoping, which is the reason I do this, I'm hoping that 100% of the ears and eyeballs that might be watching and or seeing this when it comes out says, holy shish kebabs, I want in. If somebody wanted to learn more about this, learn more about you, your company, get a hold of this, where do people get in contact and learn more?
Yeah, PeopleOneHealth.com. Of course, you can hit our website. My email, jordan.taradash@PeopleOneHealth.com. And Lester, you can give him my cell phone as well. We just want to get out there and connect with as many people as possible.
Awesome. Jordan, as somebody who I don't know why I gravitated towards this model when I was in the advisor seat. But I can tell you on every sense of the word, it was successful. It was, I had the lower cost for my employers. I got more clients for it, so I made more money on it. It was the best benefit I could give to employees. It was in a geography where it was a lot of it was in the same community. So back to that community aspect of it, it's like, wow, like the impact that you can have. And I think that's what I want to say. Thank you for your mission in that, because we forget when we do this job every day that, the job ends up impacting lives. And I always want to end with that. If people want to think it's foo-foo, they could think it's foo-foo. But at the end of the day, when you see it, right, and you see it every day, and we hear these stories, and I posted on LinkedIn this morning, a Keytruda patient, like $10,800 is what this person just saved, and they make $60,000 a year. I mean, you're talking after Uncle Sam takes theirs, we're talking 20% of their take-home pay. The stress, the anxiety, the likelihood of them doing it on something that is a very serious condition. I mean, I hope, you put your head down at night every night and sleep well, because you deserve it. Thank you for being our guest. For our guest, if you have not explored this, you need to explore this. There's nothing that Jordan said that should scare you at all, other than this is change. But I'm going to say, without change comes nothing good. I mean, a butterfly doesn't become a butterfly until it changes. I mean, it just is the deal. So Jordan, thank you so much for being a guest. Thank you for what you do for the overall mission and people. And thanks for spending 40-something minutes with us.
Thanks for having me, Lester. Thanks for your partnership.
For the audience, I've been on this kick that I read a How to Get a Better podcast, and they said the number one thing to do is to remind people to share it. So I hadn't done that before. So I am going to say, if Jordan and I gave you any level of value, I don't ask for sponsors on this. I don't try to sell anybody on this. This is literally to impact through education. If you found this useful at all, hit the share, throw it out there, send it to somebody specifically, get them in contact with Jordan, because at the end of the day, getting more people better healthcare at a higher quality at a lower cost impacts our nation. And if you think that's foo-foo, you're too far away from the core of the issue. So Jordan, we'll see you soon, buddy. Thanks so much for being on.
Thanks, Lester.
You've been listening to Impact Healthcare, people and strategies that are disrupting the health benefits industry with Lester Morales. Remember, the journey to getting 20% savings on your healthcare benefits starts with total transparency. Remember to subscribe to the Impact Healthcare podcast on iTunes or wherever you get your podcasts.